Hi everyone, welcome to Ask the Egg Whisperer. Thank you for joining me today. I'm super excited to take your questions. Go to asktheeggwhisperer.com to send in your question, and I can't wait to read it and to give my input. So let's get started. Our first question is from Melissa. Melissa says this: I got Prego pretty fast 3 times, but unfortunately I had a miscarriage every single time at 5 weeks. I found out that I had 2 fibroids, 1.6 centimeters in my uterine cavity. I got them removed through my vagina. We'll talk a little bit about that. No cuts. I'm 35. I haven't been able to get Prego since my surgery. That was in November of 2019. I've developed pelvic floor tightness. I have normal periods. I do ovulate, no other issues. Were the fibroids the real reason behind my loss? Why can't I get Prego? That sounds like an Italian spaghetti sauce, as fast as before. Melissa, I am so glad that you brought this up, and that's why I created the TUSHY Method, right? So they're the 5 tests that we do to figure out what your fertility diagnosis is. We kind of have an idea based on your fibroids, what's going on with your uterus, but what else is happening, right? What are your fallopian tubes like? We can assume you've had 3 pregnancies. It sounds like they were inside your uterus, but what if one fallopian tube is blocked and one fallopian tube is open? I think it makes sense to find out now. Let's take a look at the sperm. Do a test like Meet Fellow for those of you guys who want to do a test from home and not have to go into a creepy closet somewhere and collect a sample. Go to meetfellow.com/egg-whisperer. I get no money from recommending any of this stuff. I'm just telling you right now. I just want to make it convenient. And they'll give you guys like $20 off or something like that by going to that link. And then the other thing is looking at your hormones, right? So your FSH estradiol on cycle day 3 and your AMH level kind of give us an idea as to what's going on with your eggs. You're 35 years old. You've been trying now. You've had 3 miscarriages. Enough's enough. We got to figure out what's going on. And then I created the Angel workup. So those are also ANGEL. I can count to 5 again. The 5 things that you should think about if you've had a miscarriage. I'm sorry you've gone through that. It's devastating. It's horrible. But what if they weren't related to the fibroids, right? Like, what if? So now, the next thing that I want to make sure you realize is that the A in Angel is anatomy, the anatomy of your uterus. So ask your doctor, have you ruled out scar tissue in my uterus? And could that be present from the removal of the fibroids that's getting in the way of a healthy implantation? So just go through each of those things. And if you're like, hold on, Aimee, like, hold on. Like, you went to medical school and you obviously know all of these little acronyms and sayings. How do I talk to my doctor about these things? Like, I don't know what any of these things really mean. So just take it one step at a time, and you can just ask your doctor, have you ruled out a tubal issue? Have you ruled out that the fibroid isn't still there, or there isn't some sort of remnant or scar tissue? Have you ruled out a sperm problem? Have you ruled out an egg issue? Have you ruled out a genetic issue? And then go to, have you ruled out an autoimmune issue? Have you ruled out an endocrine issue, like something wrong with my thyroid? See? Not so hard. So I just made something that could seem so overwhelming a lot simpler. So I hope that helps, Melissa. And I hope that you have the family that you so deserve. No one deserves to go through what you've gone through. This next question is from Ella. Ella says, my doctors gave the HCG trigger shot after the IUI. Is this okay? I've done IUI on cycle day 12 twice and failed. Could this be the reason for the failures? So I've actually written a blog article why your IUI didn't work, and I have an answer for everyone, and that's because you're human. So this is the thing. The turkey baster approach, it sounds like it should work every time, right? You get like how many sperm, like even over 10 million sperm cells, and you have 2 eggs just sitting there waiting to be fertilized in the fallopian tube. Wouldn't you think that it would happen and that egg would get fertilized? I don't know, 85% of the time? No, unfortunately, when it comes to IUI, we are super inefficient at getting pregnant as human beings. And the pregnancy rate from IUIs can be even as low as 5%. It can be as high as 20%, depending on your age and the number of eggs ovulated. So if your IUIs aren't working, just think through the following things. The Tushy check, have you done it? I know, I sound like a broken record. If you guys know what records are, if you're under the age of 40, I'm going to digress. Sometimes I talk about stuff like Spice Girls, and I have medical assistants that are like, who are they? I'm like, you're fired if you don't know who the Spice Girls are. Anyways, that was a little bit of a digression here from me, but as far as the IUI not working, it is common for it not to work. If you're doing multiple IUIs and they don't work, you have to always think about, is there a fertilization issue related to the egg quality, sperm quality, or both? Is it related to some sort of anatomic issue? Have you ruled out a fallopian tube problem? So, and then you guys all know my egg whisperer golden rules. My egg whisperer golden rule is this: if you're 32 years old and you want 2 kids and you don't have one already, really consider saving the eggs. On the side of my car, I have a big hashtag save the eggs on the side. I don't. I actually don't. I actually have on my license plate, it says, if your period has started, follow me. Because, you know, I don't like periods. Because that means that my work is not done. Okay, so this next question is from Sunny Side Up. That's a really cute name. I have a feeling that your mother did not name you Sunny Side Up and you're just joking with me. And it's making me laugh, so I love it. Thank you. In fact, this is actually the binder that I keep a lot of my show notes in. So there you go, Sunny Side Up. Okay, so this question is from Sunny Side Up. Here we go. Dear Dr. Aimee, I think you're fantastic. Thank you for empowering women and men with information necessary to navigate the sometimes confusing and frustrating fertility journey. I'm in my mid-40s and had consultations with 2 different reproductive endocrinologists. I'm in my mid-40s and also have low ovarian reserve. One specialist starts with high doses of meds for the first 3 days of stem and then tapers off based on monitoring results. The rationale is to jumpstart the follicles. The other physician uses medium stems the first few days and then tapers off. I know that you've discussed using mini IVF and lower doses of meds in older women with low ovarian reserve. Yes, you are right. What are your thoughts on these 2 protocols? I'm concerned that the high or medium doses may cause damage to the eggs even if it's only for a few days. Sunny Side Up, here's the deal. How many eggs do you have? What's your follicle count? So I say this a lot, and you've probably heard me say this, less is more. When you have less, more is always more, and then that's it. So my point is this: there's a certain dose of medications I use in women who have, let's say, 10 or more follicles to hopefully get all of them to grow. If you have, let's say, 5 to 8, I kind of just sit there and look at your history and see what I think. But typically, if you have 5 or less, I like to use that mini IVF protocol. I don't want to start standard stem doses at the very beginning. That's just my style. However, just because I like to make my momlets that way doesn't mean your doctor makes their momlets that way. I often tell patients, do what your doctor feels the most comfortable with, and I promise you they're not frying your eggs. They've done this a lot. They're like behind that omelet bar, and I could never tell the omelet guy to do something that, because I don't know how to make omelets. I just know how to make momlets. But my point is that I'm not so worried. I don't know what their definition is of high stimulation doses versus medium stimulation doses. But if your doctor is starting a little bit high and then they're going to go a little bit low, I think that's okay. If they're starting medium and they're going to check in, I think that's okay. I think what they're saying is, look, I'm going to start you on a dose that I think is right for you, and then I'm going to taper along the way or go up or stay the same. And that brings me to the Sparkle checklist, right? So it sounds like they're going through the Sparkle method. It's like they know the checklist. We all know the checklist. They're going to look at the size of your follicles, confirm the protocol. They're going to say, are we happy? When's the retrieval going to be? Are we going to keep going? What does your lining look like? And what is your estrogen level? So they're going to take all of that stuff into consideration, and they're going to give you a plan. So I'm not feeling too strongly either way that one's right or one's wrong. I just feel like go with the doctor that you feel the most comfortable with. You want to go with someone who's like me? Well, not everyone's like me. Ridiculously excited to help you, and will do whatever they can until you're successful. Okay, so this next question is from Sammy. Sammy says, hi, Dr. Aimee. And you guys, this is a serious one. I mean, they're all serious, but this one has a little bit of sadness mixed in. I have 1 stillbirth in 2014 at 28 weeks, 2 miscarriages in 2017 at 14 and 18 weeks. After that, we tried to conceive but failed. Nobody could find any reason for the miscarriages. We did a biopsy of the fetus of me and my husband's chromosomes, and everything was normal. My AMH is 1, age 34, FSH 3.5, TSH 2.9. I did an egg retrieval this month, and 2 embryos are frozen. Should I do another retrieval or do another transfer? As my miscarriage reason is unknown, so I really don't know what to do. Please help. Sammy, my heart breaks for you, and I went into fertility medicine because my mother has experienced the same exact things that you did, and I can only imagine how hard it is to have experienced everything you've experienced. You're obviously extremely resilient and strong. Who knew you had to be so resilient to be a mom? But keep going, and I and I want to help you. So if you're a patient of mine, I would say, have you done genetic testing of your embryos? You don't have to do genetic testing of the embryos, and I can't tell based on your answer if you have or you haven't. But even if you haven't done genetic testing, I would say go ahead and do another cycle and perhaps consider PGTA. When patients have had miscarriages, PGTA could potentially help do what? Decrease the risk of miscarriage and increase the chance of a live birth. By transferring embryos that have normal chromosomes, you have to realize that that's not everything. It isn't. I wish it was. When genetic testing of embryos came out, everyone thought, oh my gosh, you guys, we could give everyone a 100% pregnancy rate. And then we learned, oh my gosh, you guys, we can't, because there's more to a healthy pregnancy than just the chromosomes. So looking at all the things that are in my angel workup, like the autoimmune workup, looking at your nutrition status, looking at genetics, not just genetics of your chromosomes and your husband's chromosomes, but also looking, for example, at sperm DNA fragmentation. That's something else to consider. Looking at whether you have a thyroid problem. You mentioned that your TSH was 2.9, so I would potentially get another snapshot there and see what's going on. Look at your lifestyle, look at your activity level, look at the supplements, look at the environmental toxins, look at all of those things and see what you can do to live the healthiest lifestyle so that we go forward into this next cycle and transfer knowing that we did everything possible. It sounds like you have, and it sounds like you are doing all that you can possibly do. So we have the diagnosis. The diagnosis is repetitive pregnancy losses. The next thing is potentially a slightly lower AMH. And taking that all together, you would design your IVF cycle, which you've already done, and potentially bank more embryos so that you can get, right? The first question is, what do I want and what is it going to take and am I willing to do it? So it sounds like you're definitely willing to do it by asking if you can do another cycle before you transfer. And then before you transfer, look very closely at the lining of the uterus. Look very closely at different tests that you can do on the lining of the uterus. Ask your doctor questions like, have you ruled out adenomyosis? Have we ruled out endometriosis? Is that possibly playing a role in the miscarriages that I had and the stillbirth? So talk to them about all of these things and then transfer again. My patients who've experienced stillbirths at 28 weeks, 34 weeks, and beyond, I can tell you that you're all in a very special club. And when it comes to transferring again, you're going to be so scared that the same thing's going to happen again. But I can reassure you that the likelihood of it happening again is going to be 1% or less. So move forward with your next transfer with hope in your heart and the same hope that I have for you for a successful transfer and a healthy pregnancy. This next question is from Maria. Here's what Maria says. Hi, Dr. Aimee. Thank you for all you do. You rock. I'm 29 with an AMH of 6.7 and unexplained infertility. Okay, we're going to break down that unexplained part here in a second. You can see my eyes rolling just a little bit. I'm just kidding. We tried 2 IUIs, which resulted in a chemical pregnancy and a miscarriage at 6.5 weeks before moving to IVF. My reproductive endocrinologist had me on an antagonist protocol to avoid OHSS. I got 14 eggs, 13 mature, 10 fertilized via ICSI, and we're doing genetic testing on them. What are my chances on these embryos? How many should move on to day 5? And how many should come back genetically normal based on statistics? I, for some reason, was expecting more than 14 eggs with the AMH that I have. We really only did stimulation for 8 full days before triggering on the 9th day. Thank you so much. So Maria, with your AMH level, your doctor was like, holy smokes, I got to be super careful and make sure she doesn't get sick, right? They already talked to you about using an antagonist protocol to prevent OHSS. With COVID and the pandemic, we want nobody going to the emergency room for complications from an egg retrieval. So I feel like we're all out there doing a really good job gingerly stimulating our young patients with lots and lots of eggs to make sure we're maximizing the number of eggs without putting you at any risk for OHSS, right? That would be kind of sucky to be like, I'm in a lot of pain, I need to go to the hospital, I need to be hospitalized, I need to go to the emergency room right now. Like, we don't want that. We don't want you to have problems breathing and walking and all that kind of stuff. So I typically tell my patients, my goal, no matter how high your AMH is, to get around like 12 to 15 beautiful golden sparkly eggs, right? So we might stimulate a whole bunch of eggs, and in the end, that's kind of the magic number, it seems. Study after study kind of shows that that is the magic number. Can you get more eggs and have them all sparkle? Yes. Can you get less eggs and have them all sparkle? Yes. My point is this. There's nothing wrong with you. The fact that they got that number of eggs means they did a pretty darn good job. So now, as far as the number of embryos that could be genetically normal at 29 with that number of embryos, I would say, oh, you haven't told me yet. So you said you have 13 mature and 10 fertilized. So I would say typically the blast formation rate in most labs right now, it's between 50 and 60%. You're kind of not giving me all the information. I wish I knew it. So you have to tell us so that I can tell everyone for the next show. So Maria, I would expect about 50 to 60% blast formation rate. It could be higher. And based on your age, I would expect a very high likelihood of each embryo being genetically normal. The term we use is euploid, EUPLOID. So Maria, the other thing that you're going to do is get all your official reports once you're done, and then talk to your doctor about the embryo diamonds. So go to embryodiamonds.com, and those are all the little things that you're going to ask your doctor about: what day the embryos were frozen, the implantation rate per embryo, which one's abnormal, which one's normal, which one's mosaic, get all the official reports, how did the sperm look, are they going to help me make my dreams come true? Like all of those things you're going to go through with them so that you can feel like you have all the information before you start preparing for a transfer. And then because of your history of miscarriages, we know that this isn't unexplained. Like, we know that there's an issue with miscarriages. I don't know if you've done the angel workup yet, but if you haven't, maybe still go through all of those things and do it before you transfer. And best of luck to you. I feel like you have a really high chance of being successful and having the family size that you want, given all the work that you've done and everything that you've been through. Okay, so this next question is from Cheryl. I turned 39 years old this month. My AMH was 1.5 in January 2021, but now it's only 0.67. You guys, isn't it still January? It's still January 2021. So I have a feeling she was saying January 2020. Okay, so let's just make that assumption here. I had an IVF procedure in August and 11 eggs retrieved. 1 is normal. Our doctor suggested another cycle before the FET, but I don't know why my AMH dropped so much. Is it possible that my first IVF cycle caused this sharp drop? What's the chance to have another successful IVF cycle? Okay, guys, let's break it down. So when it comes to AMH, it's a hormone that tells you basically kinda when you're going to go into menopause. Fertility doctors use it to kind of guide us as far as the protocol to use and how many mature eggs we can expect from an IVF cycle. We also use the antral follicle count in that way too. So when I see an AMH of 1, and then a year later I see an AMH of 0.6, and I know it was 1.5 and 0.67, I say, okay, I mean, that's kind of how it meanders over time. But at the same time, I would say, well, that is a little bit of more of a drop than I would expect in a year. And that's typically something that we can see in women over the age of 37, that the AMH goes down a little bit faster. So then I would say maybe we repeat it and see what it is, and see based on the first, second, and third where we average out, then we kind of have a better idea as to what to expect from you. So I think right now the best thing to do is another AMH, and then look at your follicle count and see if your follicle count is consistent with, let's say, a follicle count of 7 versus a follicle count of 11, then you'll kind of know where you're at. I think your chances are still pretty darn good to get another normal embryo, given that your last cycle was in August. So I would, if it were me, and I would do another cycle and see if you can get more embryos before you transfer. And since your embryos are so precious, remember the E of the Egg Whisperer diet, and that's embryo transfer. Every time I'm like, what is it? Just kidding. Endometrial receptivity testing or embryo transfer preparation, whatever you want to think of as far as like getting ready for the transfer, that's the E of the Egg Whisperer diet. Okay, so this next question is from Miriam. Miriam said, after a successful fresh ICSI cycle and a hopeful NIPT result. So what that means is she did the NIPT, which for those of you who don't know is a cell-free DNA test that looks at some of the chromosomes from the placenta, from the cells from the embryo, and they tell us if the embryo for the most part is normal or not. It is not a diagnostic test. It is a screening test. So it doesn't tell you for sure until you actually either test the pregnancy with an amniocentesis or deliver a baby. My pregnancy ended at 21 weeks. The baby measured 16 weeks, and she consistently measured about a week smaller in all my appointments. I'm 37 and don't have a frozen embryo. What should I do differently? Do you recommend PGS? I have tubal infertility and need IVF to get pregnant. Thank you. Okay, so Miriam, first of all, I'm really, really sorry that you experienced that. I'm curious if that pregnancy had trisomy 18, for example. I wonder what genetic testing was done. Still go through my angel approach or that method. So look at all the things that I talk about. It sounds like maybe your AMH level might be low because when you went through a cycle and had 1 embryo to transfer, that might mean that you might have lower egg quality. Remember that saying, low does not mean no. I say that all the time here for you guys to hear. So you remember that. You're like, my doctor says that my egg quality is low. And then you're going to be like, ding, the Aimee angel Auntie Amy on your shoulder. Low does not mean no. Just cracking myself up over here. So back to your question of, do I recommend BGS? And given your tubal factor infertility, the answer is yes. I mean, after what you went through, finding out at 21 weeks that the pregnancy stopped growing at 16, I don't want you to go through that again. But this is the thing. These are the conversations that I have all the time with people because I've lived through these experiences with my patients as well. So we say the following thing. Look, Miriam, if you did IVF again and had a miscarriage, would you be able to keep going, keep moving forward, and keep trying? What would you do if you had another miscarriage, right? If having another miscarriage, and it's always debilitating and horrible and just depressing, but if it would really set you back so much that you might not be able to move forward and you would regret not doing genetic testing on the embryo to prevent that miscarriage, then I would say do testing. So I have patients that say to me, Aimee, I can never, I want to do everything possible to prevent a miscarriage again because I cannot live through another one. And I totally get it. And I have other patients, believe it or not, believe it, because a lot of you guys have shared these stories with me. They say, Aimee, I get it. Whenever you say, I want to be pregnant, and you say it and you do it, you're also saying it. Actually, you're not saying it. You're also subconsciously saying, and I accept the reality that not every pregnancy is going to end in a live birth and not every baby is going to be healthy. And that's just called life. So, you don't have to do genetic testing, but I do think in your situation, it would make a lot of sense, Miriam. Okay, this next question is from Elizabeth. Elizabeth said, hi, Dr. Aimee, I transferred 2 PGS normal embryos, a day 5 3BB and a day 7 6AA. I got pregnant, but it ended up being an ectopic pregnancy. And they found out that one of the embryos split in my right tube. Can you guys imagine that? I cannot imagine, Elizabeth, being in that ultrasound room and seeing that. That's quite a lot to go through. Although no damage, the right tube was removed because methotrexate hasn't been effective when 2 embryos exist. I'm recovering and plan to do another FET early next year. I'm 40 and I have 3 PGS graded day 5 and day 6 embryos that are normal. Should I inquire or do any more tests or assume this FET was just bad luck? Because it implanted in the tube, does that mean I was receptive? I'm starting to lose hope, but plan on doing a natural FET versus medicated next time. Thank you so much. Okay, Elizabeth, let's break it down. Okay. What's your diagnosis? We know you're 40, right? But you're 40 with dang good eggs. 3 PGS normal embryos still that you have left after transferring 2 embryos. It's holy smokes, that's great. So it seems like there might be an anatomic issue, right? Because you told me you had an ectopic in that right tube. So what's going on with that left tube? That's what I want to know. You did have surgery, and at the time of laparoscopy, they probably peeked at that left tube because they were so worried about you. They probably didn't think, I wonder what's going on with her left tube. Should we do a tubal dye study? So if you were a patient of mine, that's what I would do. I would say, look, let's do a hysterosalpingogram and take a really close look at that remaining tube. If there's any possibility of scar tissue or if it looks dilated, we should remove it because believe it or not, you're at higher risk of having another ectopic. It does happen. I've seen it. I've heard of it happening. I've had patients experience those kinds of things. I've lived through some of these things where someone has an ectopic and then we find out the other tube is blocked and we do a surgery to remove that tube to prevent you from having another ectopic pregnancy. So that's what I would ask your doctor to do. Could it be bad luck? It could be, but I also don't want it to be a recurrent thing because sometimes you can have recurrent ectopic pregnancies. And some of you might be listening and you're like, I'm so confused right now. She did IVF. They put an embryo inside her uterus. How did they go into the tube? How? And the reason is there's a little opening. They're called ostia. They connect the inside of the uterus to the fallopian tube. They're connected. So once we put in an embryo, there's no embryo stapler. I wish I could be stick. There isn't. I talk about the lining of the uterus like peanut butter and those little embryos like peanuts. And you shake that jar and they don't go anywhere. But the reality is they kind of float around a little bit and they can float around into a tube and get stuck there. If the tube is normal, that embryo can be pushed back into the uterus, theoretically. If the tube is not normal and blocked, the embryo will get stuck. So that's why knowing if your tubes are open before IVF could be helpful. And that's why in a patient who's had an ectopic pregnancy after IVF, it may not, it's obviously bad luck. That really sucks. You're not hexed. But there might be an indication to just check that other tube so this doesn't happen again because it can be recurrent. Okay. This next question is a good one, you guys. This is from Sarah. And Sarah says, what does indeterminate mean when testing comes back on embryos? So this is the thing. Your official reports, remember the embryo diamonds? Those reports, if you've done genetic testing, you'll get a piece of paper. That piece of paper will say embryo number 1 is euploid, embryo number 2 is aneuploid, embryo number 3 inconclusive. You're like, what? Inconclusive is another way of saying indeterminate, which is another way of saying we can't really tell. It could be because of the biopsy technique that was used. It could be because someone didn't screw on the cap on that tube where the embryo was put in. I'm just kidding. It could be some sort of handling on the other side in the IVF lab. So if I have a patient and there's an indeterminate result, I get kind of annoyed. It happens very, very rarely for me, maybe 1% of the time, thank goodness. And I think that has a lot to do with the amazing embryologists that I work with. So that is a question actually that you can ask when you're doing IVF. You can say, what percentage of embryos come back inconclusive or indeterminate? If the percentage rate is actually quite high, you have to wonder, maybe I should not do genetic testing with this lab. If they say it's about 1%, you're like, thumbs up, I feel safe in this lab. So that's kind of one thing that you can use, or one question you can ask to figure out whether you should do genetic testing in the lab that you're with or not. The other thing is, even if it comes back indeterminate or inconclusive, it doesn't necessarily mean that they don't have any data. So what I do is I get on the phone, MD to PhD, I'm talking to that PhD geneticist, and I'm like, tell me, what do you see? They're not going to put it on the report because they don't want to put things on the report that aren't 100% accurate as far as the, I mean, nothing's 100% accurate, but you know what I mean. And then she'll tell me like, Aimee, I think it's normal, but I can't really say because there was this, that, and that issue. Or they'll say it looks most likely abnormal, like I can tell, but because of this or that, I can't really, generate a report about that. So that's why it's important to have your doctor step in when you see that so that you can get all the information. And I would say that most doctors are honest and transparent about this stuff, but some doctors, they just don't have the time to pick up the phone and call people, or they actually didn't know. I like to talk to people. Surprise. I know. Surprise, surprise. Some people just don't pick up the phone. It's an easy call to make. Like today, I called a radiologist. I said, hey, I don't agree with that HSG report that you just generated. Can you look at that again for me? Because this is what I see. And he's like, oh, yes, let me redo that and send it right back. I'm like, thank you. Okay, this next question is from Shamila. My AMH is low, 0.087, and FSH is high at 9.95. I've done one IVF cycle that didn't work. I want to conceive naturally. Is it possible to conceive naturally? Yes, it is. I'm taking CoQ10, 200 milligrams, DHEA, folic acid, 800, and omega-3, and pregnant care for conception multivitamin. Please, can you suggest that these are the correct medications or supplements for low ovarian reserve? I also have lots of urine infections. I wonder if I should be taking probiotics. What should I do for my UTI problem? Due to this problem, I have the problem of sex. I can't enjoy it because of all the UTIs. Please suggest, what should I do? I want to conceive as soon as possible. My age is 39. Okay, here's what I would do. It sounds like you're totally willing to be as aggressive as possible. Go do it. It is not unusual for it to take several cycles before you're successful with one healthy embryo. However, we have to say to ourselves, look, with your AMH of 0.08, what that means is you might get one egg per cycle, but we have these waves of eggs in our ovaries, right? These follicles. We have to say, and it's okay to say it, you guys. It's okay. You say, it might be too late for me to have a healthy pregnancy with my own eggs. You have to say that, because if you don't say that, the reality is that you want to be a mother one way or another. And so it might be time to think about other options. However, what you have to ask me is, Aimee, have you ever seen a patient with an AMH of 0.08 and FSH of 9.95 still get pregnant, either naturally or with IVF or even IUI? And the answer is, I have. Does it happen a lot? No, but it happens enough that I would tell patients to keep trying if you feel like that's something that you want to do. However, if it's too emotionally taxing, if it's too financially, financially it's too hard, then it makes sense to say, okay, if I have a 5% chance to do this and an 85% chance to achieve my goal with that, I would choose the 85% chance, even if it means not using my own eggs. Okay. So, and the other thing is there's no emergency here. You have all the time. Most doctors help patients get pregnant with donated eggs in their 50s now. So back to your question about the UTIs, there's this really cool thing called the Peri bottle. The Peri bottle is this clear bottle. It's basically like a sports bottle. It has a little cap. You just pull up the cap. It's like a sports cap on those water bottles. before sex, after sex, you're going to use it. It's kind of like a little bidet. If you don't have a Japanese toilet, I recommend looking into them because that's another way of getting this done without using a peri bottle. So you fill up with some warm water, maybe some mild soap, and you just basically pee before sex, squeeze it, go pee, go have sex, and then after sex, you'll be like, excuse me, I need to go, go to the bathroom. So don't sit there for more than like 10, 15 minutes after sex. Go do the same peri bottle thing, and you should be fine. If that doesn't work, or if your urine infections are all the time, you can actually take chronic suppressive doses of an antibiotic like Keflex, Macrobid. These are pregnancy safe. You just take one 30 minutes before sex. If you forget, if you're in that moment, like those telenovelas, you're like, I forgot my antibiotics, right? When is it really like that? Almost never when you're trying to conceive, but we can only dream or imagine. But the reality is, even if you take the antibiotic after sex, that's also okay. So don't worry. So talk to your doctor about prescribing antibiotics, a pill like Macrobid, for example, 100 milligrams per day, using a peri bottle, and hopefully your UTIs will go away. Okay. This next question is from Aimee. Hi, Dr. Aimee. Thank you for your wisdom through these shows. I'm wondering if you've seen much success with patients going back to IUI after IVFs that don't work. I know the success rate for IUI are not great, but after 27 eggs collected, the odds for me for IVF don't appear to be in my favor. Here's what I've done. 3 IUIs with a trigger shot. My lining was never good. IVF short protocol with gonal F and ganirelix. 8 eggs, 6 mature, 3 fertilized, 1 morula. I then switched doctors, and I did an IVF long regulation with gonal F, 9 eggs, 7 mature, 6 fertilized, 1 4BB embryo, and then I did a long cycle with Menopur, 10 eggs, 8 mature, 7 fertilized, 1 5AA embryo. I'm using donor sperm to be a single mom and have never been pregnant. My doctor keeps saying I produce eggs, so we should keep trying, but my heart is so broken. I don't think I can. Any thoughts would be wonderful. Thank you again for everything, Aimee. Aimee, I don't know if you've heard of embryo donation. You would be a great candidate for that if you agreed. Look, you've done 3 IVF cycles. You're using donor sperm. How about use donor eggs too? And then guess what? You don't have to create a new set of donor sperm embryos. You can use embryos from someone who has unused embryos, if that's acceptable to you. Embryo donation is a wonderful way to grow your family. It truly is. I do about probably 4, maybe not 4, but maybe I'll say 2 to 3 embryo donation transfers per month. It is a very high touch program for me. So what I would do is meet you, talk to you, get to know you, and then I would think. I've been around for a while. I know this is a baby face of someone who just started her practice 6 months ago, but no, I've been here for over 13 years. So you can imagine all the families that I've helped. And I have a rule. If someone wants to discard embryos, they're not allowed to until they talk to me. And then I say to them, have you considered donating your embryos to somebody who needs them? And then I would say like 50-60% of the time, my patients are like, yes, that sounds like a great option. I didn't even know I could do that through you. I was wondering how I could do that. So thumbs up. Then I would have them write a bio. You write a bio with photos. We do a little swap of bios. And then we say, how do we feel? And then from there, everyone talks to a psychologist. The psychologist moderates a meeting for everybody. And then we do a legal contract. And then we have a baby. I wish it was as simple as that. A lot of times it is. But think about embryo donation. And if you still feel like you want to try with your own eggs, go for it. The fact that you made a blastocyst despite 27 eggs doesn't mean that you can't get pregnant with IUI. As long as your fallopian tubes are open, I still think that it might be worthwhile doing IUI. I have been successful before in women who are 39 who've even done 6 IVF cycles. I'm thinking about her right now. Her daughter's photo is literally on my piano. That is not a joke. It really is. This next question is from Nanda. Hi, Dr. Aimee. I'm O negative, husband A positive. My firstborn was fine. My second had really bad jaundice due to blood incompatibility. A few months ago, I got tested for RH sensitization, and everything looked okay, so we went ahead and tried for a third. I got pregnant, but I had a miscarriage. Then again, another miscarriage, and another. I didn't get the RhoGAM shot after the first 2 biochemicals, but it was done after the 7-week miscarriage. Does blood incompatibility put women at a higher risk of having miscarriages? Is there anything I can do to prevent it besides switching husbands? Ha! That's a really funny thing. That's hilarious, actually. Yes, you can find an RH negative new husband. There should be like a bloodmatch.com. Find your husband based on his blood type. There probably is something like that out there. I just don't know it. Second question, the doctor that performed my C-section mentioned that I had adhesions from the first one and a small fibroid. What test do you recommend? I asked my doctor. And family doctor wants to help, but isn't trained in recurrent pregnancy loss. And unfortunately, I might not qualify for seeing a specialist because the first two miscarriages were biochemical. Nana, that's really hard. I mean, for me, every miscarriage or every pregnancy test that's positive for me is a loss. Because in that moment, you imagine that you are a mother. And then it was cruelly taken away from you. And so anything I can do, any tests I can do to figure out why this is happening so I can potentially do something to prevent it, I want to do. But I totally get it. Like, there are rules that insurance companies make that, like, people say you can't have this workup until this has happened. They define what this is. And I find that incredibly unfair. So you might want to say to your doctor, look, can you just do the workup for me and I'll pay out of pocket for it? I mean, if you think about the cost of going through a miscarriage and all financially that you had to pay for, potentially, you know, doing the testing, the cost of that might actually be lower than, and if you could fix something, could be lower than the cost of a miscarriage. So my thought process is this. It is possible that Rh isoimmunization or Rh disease can cause miscarriages. In general, in my experience, they're not causing early miscarriages. So I feel like we still have to look beyond that. So look at your AMH and your egg quality. Think about scarring of your fallopian tubes. So if your doctor said you had really bad scar tissue around your C-section scar, then I wonder if that also means that there might be a tubal issue, and that's why you're having these biochemical pregnancies. So if you haven't done this already, I would recommend doing a hysterosalpingogram and take a look at where the fibroid is located. If it's located anywhere near inside the cavity of the uterus, I think it would make sense to do a saline sonogram followed by a hysteroscopy if there is a fibroid present. And as far as the recurrent pregnancy loss, that's why I created the angel workup, right? I mean, you just go through it. Rule out something in your uterus, scar tissue, look at the anatomy, like your fallopian tubes in your case, look at your AMH level, that autoimmune workup, and then look at all the other things like chromosomes for you and your husband, sperm DNA fragmentation testing, especially if his count is low. Look at, for example, endocrine abnormalities like thyroid, diabetes, lifestyle, and nutrition, okay? So I hope that helps. And take CoQ10. I feel like I haven't said that today. You guys always hear me saying, take CoQ10, take CoQ10, take CoQ10. So I want you guys to take CoQ10. And the thing is this, food is medicine. You don't have to take CoQ10 to get CoQ10. You can just Google like foods that give me CoQ10 and look at that and eat those. Like I like broccoli. There's CoQ10 in broccoli. That's good for you. And then you don't have to buy CoQ10. This next question is from Rashida. Hey there, hubby and I are doing IVF next month. Our issue is male factor infertility. 6 million total motile count, 18% motility, 0 to 1% morphology. My AMH is 2.88. My doctor says mini IVF, 200 milligrams of Clomid with an ovidral trigger and ICSI will give us one good embryo to transfer. How many eggs can we really expect to be retrieved with mini or full? RE says 4 versus 10. What should we do? Thank you so much. I love your humor and energy. Rashida, do a full IVF cycle. Trust me. See, I'm very bossy. Obviously, you can do whatever you want. I'm just hanging out here talking to you guys and having a blast sharing, you know, I mean, like, there's nothing more fun. Like if someone said, Aimee, you have to go on vacation. You have to go to a beach somewhere. I'll be like, well, can I help anyone get pregnant when I'm there? I had a girlfriend. This is a true story. She's 50 years old and she's calling me. She's like, hi, how are you doing? I have a medical question. I'm like, oh, you want to get pregnant? And she's like, stop doing that. Anyways, okay. So back to your question. The reason why I want you to do a full IVF cycle is not because there's something wrong with your eggs, right? What is the unknown? We don't know what the fertilization potential will be of the sperm, right? I mean, we can say, oh yeah, if you do ICSI, that's going to fix everything. But that's not true. Every embryo takes an egg and a sperm cell. So if the sperm quality is low, that might end up in lower quality embryos. So the more eggs you have, the higher the chance that you're going to have a juicy, gorgeous, sparkling embryo, and the higher the chance that you're going to have a healthy pregnancy. Go through my balls method. I have a feeling you already know what that is. So look at his sperm DNA fragmentation, okay? Rule out a varicocele, look at his testosterone, get him on supplements, get him out of the hot tub. If he's in there in a bubble bath every night, get him out and tell him, stop eating those gummy bears. I do all these video consults and I'm like, I know it's 100% legal in this country. Are you guys, not in this country, in California, are either one of you eating gummy bears? And I see the husbands going like, I'm like, stop it. No more gummy bears for you. It's really fun for me. Until your wife is pregnant. And then you can have a gummy bear here and there. If you don't know what a gummy bear is, Google it and then put California and come to my house because they'll drive to your house now and bring you gummy bears, apparently. Okay, so yes, full IVF. Thank you, Rashida, for asking that question. Super fun to answer that question. So this next question is from Hillary. Hillary says, thank you for the time to answer this question. Here we go. I've been on Humira for 12 years since I have uveitis in my right eye. I was wondering if Humira is safe in pregnancy or can cause any issues to the embryo or even issues to conceive. So Hillary, the answer is I have not seen a patient have a complication from Humira in pregnancy. I actually have a lot of, not a lot, I have enough percent, I have seen, I would say, enough patients who take Humira for issues like Crohn's disease and other types of autoimmune issues that have done wonderfully in pregnancy. So I tend not to stop the Humira or think that you need to stop in pregnancy. So I think probably the best thing to do is talk to your OBGYN, talk to a high-risk OBGYN, and have them shake on it and say thumbs up on Humira so you're getting the right messaging throughout so you're not worried. This next question is from Rennie. Rennie, I'm going to take a little swig of my coffee. You can notice my fun little mug here. Okay, here we go. Rennie is saying, hi, Dr. Aimee. I'm going through IVF and I'm over 40. My husband and I were trying to get educated on egg donor options in case it doesn't work with my own eggs. Here we go. Which egg banks do you recommend normally to your patients? We watched an episode of you talking to Fairfax. Are there any others you recommend? I'm South Asian and it doesn't look too promising to find an egg donor with my ethnicity. Are there any international banks you would recommend? Okay, Rennie, here's the deal. There's something going on called COVID. I know. You're just like, seriously, did you just say that? Because that's kind of annoying. Yeah, so COVID has really affected the number of Asian donors we have in this country because a lot of the agencies were actually bringing them from overseas. So now we don't have as many. Are there Asian donors out there? The answer is yes. It's just all about timing. So make friends with all the egg bank directors. I'm friends with all of them. I'm just like, I have a scheduled email every day at 1 p.m. Do you have any Asian egg donors? Do you have any Asian egg donors? And they're like, yes. I'm like, reserve 6 eggs. It's not that bad, but it is. So it's basically one of those things where it's literally timing is everything. And these donors come up for availability, those lots, every so often. And you just have to like wait for it. They're there. Then you go reserve the eggs and you move on. So I don't know how important the different ethnicity is for you, but I would say if you want to narrow down that search and be very, very specific about the type of donor you want, then perhaps working with a concierge service like donorconcierge.com is one option. You can go to Tulip Fertility. That's kind of like the kayak for egg donors. I think they're a great service as well. The other egg banks that I love, Donor Egg Bank USA, World Egg Bank, Ovation Egg Bank, 1, 2, 3, and Simplify with PNWF, also my favorite. And then, of course, there's Fairfax. I also love Dr. Diaz's egg banks. You guys look, see, like, I love other people, like other doctors. I'm like, you guys are awesome. You make me look good because I'm able, not me look good. You help my patients and that makes me happy, right? So Dr. Diaz has a wonderful egg bank. I think it's Global Egg Donor Bank, US.com, something like that, like fantastic. And then there's also Dr. John Jane with Santa Monica Fertility, phenomenal egg bank as well. So I don't think you can go wrong with these 7 folks if you're looking for frozen eggs. Okay, this next question is from Olivia. First, thank you so much for all the knowledge you bring to us. I'm 35 in July 2020, and following your TUSHY method, I did an AMH test for the first time, and here we go. It was very low, at 0.39. So low, so low. All other hormones are good. Then I started taking prenatals, DHA, and CoQ10, no other changes in health life or other meds. Then did another test in December of 2020 in another lab, and this time, 0.2. So this time, so low. Higher than in the minimum, but still low. Both tests were done on the second day of my cycle. As I know you can't improve AMH and it's stable during the cycle, can the vitamins be the result for this improvement in a few months? I think what you mean is the opposite. I'm happy for better results. I think I'm confused. It looks like, well, let's just say it's 0.2 to 0.39. Can vitamins be the reason for a change in results? And I'm wondering if DHEA will help as well and what doses. All testosterone results are good. Any advice? Yes, Olivia, here's what I would do. You're 35 years old. I want you to have at least 2 kids. See, that's my priority, not yours. So you have to tell your doctor, this is my priority. Please help me reach my goals. So in addition to the CoQ10 that you're taking, I would also have you consider taking NAD. I also recommend pterostilbene as well. I have no relationship to any of these companies. I'm just kind of showing you stuff that I actually take. And you can find something similar and realize that some of these things have side effects. For example, NAD can make you feel a little bit anxious, a little bit hyper. Are you surprised that I'm on it? No, I'm like this. I was born like this. Like I came out talking like this, acting like this, and trying to help everyone get pregnant. But the reality is, I would recommend that you talk to your doctor about preserving eggs, embryos, or both. And I would freeze eggs if you are not interested in getting pregnant right now. I would make embryos if you would be okay. If you're a solo mom by choice, I would make embryos now, or maybe do a combination of eggs, embryos, or both, and then go for it. As far as DHEA, there is a micronized version on the Theralogics website. You can use code TUSHY, all caps, to get the PRC price. And that is a supplement that I do think can help in women potentially, who have a low follicle count. So get that follicle count checked. That is the AFC, the antral follicle count. See what it is, and then ride that wave. And what I mean by that is find out how many eggs you have, and then ride the wave and take that wave to the shore, which would be your egg retrieval. I don't know if that analogy makes sense. It's just really fun to say right now. This next question is from Shags. Shag says, I'm 37 from Dubai, did my egg retrieval in October, did ICSI, and then I had day 5 embryos. I've had 3 C-sections before, so there's a small cesarean scar defect there. So my doctor referred to laparoscopy, where the doctor checked and said, it's so small, there's no need for it to be treated. So in December, we scheduled a frozen embryo transfer. And then I did a mock transfer where everything went well. The catheter reached the spot, and then some fluid was aspirated. And then while transferring my embryo, the catheter got bent up in the cesarean scar defect and didn't go further. I really want to know what could be the reason. Okay, Shags, here's what I would do. You need something called a hysteroscopy. But even before that, consider doing some more imaging. Consider another pelvic ultrasound or a saline sonogram. You can also consider a pelvic MRI. And it sounds like you've already talked to a doctor for a laparoscopy, and it may be time to talk to them again. And then really, really, really think through this. Having a cesarean scar defect like that puts you at risk for having abnormal placentation. What that means is you're at higher risk of having the placenta actually grow into that C-section scar. That's one of the scariest things that you can have. One of them. And it can cause massive amounts of bleeding. It can cause you to have a really bad C-section experience requiring lots of blood transfusions and stuff like that. So be sure to really think through, do I really want to go through a 4th C-section? If the answer is yes, then I would see that laparoscopist again and say, can you take another closer look, maybe do a pelvic MRI before deciding that I really don't need a laparoscopy, because my doctor couldn't even get the catheter in the right spot because of the defect. So that's my recommendation to you. The other thing is, sometimes in cases like yours, when it's really hard to get a catheter in, doing an embryo transfer under anesthesia can certainly help. So ask your doctor, would it be easier for you if you did anesthesia for me for the embryo transfer? I'm happy to be knocked out so that I can get knocked up. Okay, this next question is from Vicky. Vicky says, how have your levels been going on NAD? I know you said taking the supplement to see if it affected you when you hit menopause, and that you've been checking your AMH FSH to monitor. It's actually been really good. It's nuts. I will reveal it very soon. I'll probably check it in about 2 weeks again, and then I'll let you guys know. Thank you, Vicky. Also, how many of your patients do you see a difference from one round of IVF to the next when they start taking it? We've never made it to a blastocyst. So Vicky, I actually have had patients who did, let's say, 3 cycles, 5 cycles before taking it and never had a blastocyst. They take it, then they have a blastocyst. Sometimes that blastocyst is normal and sometimes it's not. But I have seen situations, I don't know the percentage rates. I mean, I should have like a statistician in my office at all times kind of, running these numbers, because they're pretty fascinating and very cool if you ask me. This next question is from Grace. Grace says, injectable progesterone or vaginally inserted progesterone, which is more better? I like that. That's how I talk, more better, or effective. Okay, Grace, here's the deal. If you skip one, your efforts are done when it comes to vaginal progesterone. That's what I tell my patients. Vaginal progesterone, in my experience, is just as good as injected. So with vaginal, it's 8, 2, and 8, never be late. I actually just came up with that. Maybe not this moment, like 2 days ago. I thought it was pretty funny, so I've remembered it clearly right now to share it with you. But the reality is, please don't be late. Like, call your mother, tell her to call you, tell her to set alarms, tell your partner to call you, set an alarm. Set an alarm on your phone, set an alarm everywhere so that like everything starts going off so you are not late. Leave an extra vaginal progesterone in your car, in your purse, at work, at home, like have it everywhere and never run out, because it is not an oil. It does not accumulate in your body. So there's no like window of time where you're like, oh, it's okay. I can be late 3-4 hours and I'll still have enough progesterone. No, if you skipped an insert, there is no progesterone. Your progesterone will go like that if you're doing a frozen embryo transfer. So that sounds really scary, right? So if I look at a patient and her eyes are going like this, I'm like, progesterone injection is for you. No vaginal insert. And I have a funny patient, very, very funny. She calls it Fund It. Why? Because that vaginal progesterone is disgusting. It causes this vaginal slime. It's just so gross. You can use underwear. A patient of mine said it worked lovely for her, and that's the Thinx underwear, THINX, that pee-proof, the moisture-proof underwear. She said it works great, so she's not constantly putting panty liners in and pads for all the slime. Are you guys tuning out now? That kind of, this is fun for me to talk about to help you guys with this. And then there's the progesterone shots. It's like having big knots in your butt. Some patients call me and they're like, Aimee, I have 4 butts. Is this normal? And I'm like, unfortunately, it is. So my tips for that are to warm up the oil in the syringe, maybe under your armpit, under your butt, right before you do the shot. Put a little ice on your butt after the shot. Put a little heat on your butt and do a little massage, massage, massage. And don't ever say, oh, this is so easy. I don't know why people are complaining. It's going to bite you in the butt. That first shot doesn't hurt, because that's what everyone says. I get that email the next day. Aimee, that was easy. It didn't hurt at all. And then you come in and you're like, hobble, hobble, hobble. Oh, now I know what you're talking about. Okay, not to scare you. I mean, that stuff is evil, but some people prefer it over the vaginal slime. Okay, let's move on to this question. D is saying, Dr. Aimee, I love your show. I'm 28, AMH 6.5, AFC 22 with a recently resected uterine septum. Husband has 2% morphology. We tried 2 IUIs with letrozole, third one with letrozole and Clomid, but all 3 failed. First IUI, 1 follicle, 20 millimeters. Second IUI, 1 follicle, 18 millimeters. Third follicle, 3 follicles. Third IUI, 3 follicles, 18, 15, 15 at the time of trigger. My question is this: whether the clinic is asking me to trigger too early. At what follicle size do you trigger with letrozole and Clomid cycles? And would triggering too early result in a failed IUI? We're debating if we should continue IUI or proceed to IVF. Thank you so much. Okay, D, let's break it down. What is your diagnosis? We know that you had a uterine septum. Question for you, ask your doctor, have you ruled out any remaining uterine septum? Is it possible that it hasn't all been resected? Question number 2 is this: have we done everything possible to make my husband's sperm sparkle? Has he seen a urologist? Have we ruled out a varicocele? What is his DNA fragmentation? Are we really wasting our time doing IUIs? That's what I would ask. Is he taking supplements? Is he smoking weed? Is he drinking too much? Has he been spending too much time in the hot tub, steam room, or sauna? Is he sneaking, chewing tobacco? And lastly, is he drinking too much wine? So that's what I would go through. And if his morphology is really low, it is possibly more difficult to get pregnant with IUI, possibly. And I use that DNA fragmentation test as a traffic light. Red light, move on to IVF. Yellow light, let's see if we can improve things because we're in that range where it makes sense to do so. Green light, we're all good. Consider more IUIs. And then the other thing is your AMH of 6.5 and AFC of 22. You haven't shared with us that you have any symptoms of PCOS, but also ask your doctor, have you ruled out PCOS? Have you looked at it? Is there anything I should consider doing? Taking Ovasitol, adding CoQ10, taking metformin. Look at your body size, look at your testosterone levels, ask your doctor for a PCOS workup. So to get to your question though, as far as your follicle sizes, they're pretty juicy. I mean, 20 millimeter, 18 millimeter, 18, 15, 15. I don't think based on those sizes that you're triggered too early. I like to trigger my eggs at 20 to even 24 millimeters in that zone, 20 to 24. I use Femera for so many reasons more than Clomid. But if your doctor loves Clomid, I'm going to stay out of that. I'm going to be like, sorry. I know that sounds like a really jerk move on my part, but Clomid, I would never take it if it were me because it would make me feel like I needed and exorcism afterwards. When patients are like, well, my friend took Clomid and it worked for her, and I'm like, okay, well, find the local church and find a priest and then ask them what they're available when you're done, because you might need an exorcism. And then they go and talk to their friend and they're like, oh yeah, the friend said that she almost quit her job. She almost divorced her husband. I'm like, uh-huh. Yeah. No, for the most part, Clomid can be well tolerated, but Femara does not result in you feeling like you need an exorcism for the most part. Okay. So next question is Shelly. I'm 27 years old with PCOS. Husband and I have been trying for 2 years. We got our levels checked. His sperm came out perfect. We're moving on to IVF this upcoming month after a year of timed intercourse with medicated cycles. My doctor wants to put me on birth control pills, but I don't want to do that. So far, my period has been regular every month, so we know the start of my cycle. I've done some research and found that the antagonist protocol has a low OHSS rate. Can I have a successful IVF without going on birth control? Can I do the antagonist protocol without going on birth control? Shelly, the answer is yes. Birth control pills can be used to prevent OHSS. Your doctor can also use it as fertility planning pills. I know it sounds confusing. You're like, what? I want to get pregnant. Does my doctor know that I want to get pregnant? And why did I go to the pharmacy and I see something called birth control pills ordered for me? So we do use them in patients who have lots and lots of eggs, boatloads of eggs to suppress their ovaries, but you don't need them. They're not required. So if you were a patient of mine, you're like, I don't want to take birth control pills, I'll be like, okay, we can still have a successful IVF cycle. And if I'm worried that you're going to have OHSS, well, I'm going to have you start your stimulation, come back after 2 days of stim for an estrogen level check, and then tell you, I'm not going to tell you what you're going to do that night until I get your estrogen level back. Then I'll tell you what to do that night, and then you're actually going to come in. So we're going to see each other a lot. I have some patients that are like, so how often will I be seeing you during my cycle? I'm like, 5 or 6 times. They're like, okay, well, and how long of a period? I'm like, 10 to 12 days, we'll be friends by the end. Okay, last question is from Molly. I love that name, Molly. I think I always wanted to be a Molly. Don't I look like a Molly? I kind of look like an Aimee too, but Molly I've never met a Molly that I didn't like. Dear Dr. Aimee, I'm 32 years old and my husband and I have just started trying to conceive. We've only tried for 3 months. My concern stems from the fact that I suffered on and off with anorexia for 10 years. I'm now 3 years in full recovery, weight restored, and have had regular periods and ovulate on my own ever since. I had stage 1 endometriosis treated through surgery. My tubes are open, uterus looks great. I'm currently waiting blood tests for my hormone check, which I requested per your TUSHY method. Thanks so much. Strong work. Do you think my previous eating disorder will have a lasting effect on my fertility? Have you ever had patients with similar pasts, and do you suggest we move on to any kind of fertility treatment? My husband has a double plus sperm. He's 34, as the nurse told us, so I worry it's me. My mother got pregnant so easily, and my grandmother had 8 children. Thanks so much for your advice and all you do for fertility awareness. Okay, Molly, it sounds like we are doing great. Congratulations on getting here. That is awesome. Let's not shame yourself into thinking that you caused this or deserve this, because you totally didn't. The good news is that your periods are regular now. So any lasting effect from the anorexia, it's pretty much gone. However, we know sometimes that severe stress may affect how our eggs and the pool of eggs grow. And what I mean by that, the rate of depletion might be faster potentially under severe stress. That there is a possible theory there. So I think finding out what your AMH level is going to be super helpful. So you've done the TUSHY check. I think knowing what your hormone levels are will give you all the information you need so you can plan your family. You're 32 years old, Egg Whisperer golden rule. If you're 32 and you don't already have 1 kid and you want at least 2, freeze your eggs, embryos, or both. So that's what I would recommend doing. We talk over and over to young women, and you're young at 32, about freezing eggs to preserve your future options. And we just don't do that enough for young couples who are starting their fertility journey. So I'm so glad you asked this question. I want you to just leave the past in the past. Congratulations on all the great things that you've accomplished in your life. And moving forward, know that you didn't cause any of this to happen to you, and you didn't deserve it. So I'm hoping that your AMH will be great. And if not, that's totally okay. We can work with whatever you have, especially because you're 32 years old. And it sounds like you're going to have a good pool of eggs because you have nice regular periods. Take your CoQ10, talk to your fertility doctor, and make a plan that feels really right for you. Okay, guys, I'm going to rock these live chatted questions now. So we'll start here. I'm going to start from the top and we'll go down. Here we go. Hi, Dr. Aimee. Thanks for what you do. I'm 7 weeks and my clinic wants me to stop progesterone suppositories. Can I continue up to 10 to 12? And the answer is yes. I continue my patients until they feel comfortable stopping. Does that mean they're going to stop at delivery? No, they're going to stop maybe at 10 to 12 weeks. Usually at 10, we have a conversation. Do you feel comfortable stopping? And if the answer is yes, they stop. If they want to keep going, I say, well, let's stop at 12. And they're like, I don't want to stop at 12. Then I'm like, well, let's arm wrestle and see who's going to win. I'm just kidding. Then we can taper until 14. Thoughts on mini IVF for a low AMH and 4 unsuccessful rounds. Age 39, AMH 1. My thoughts are thumbs up. That's what I call the Aimee protocol. I just called it that. Just a combination of fertility pills and injections, and then you get watched very closely, and then you do your egg retrieval, and voila, you could have a good chance of having a healthy embryo. And good chance is all relative. It really just depends on your age, but talk to your doctor about what those chances are. Okay, so one girl's hair obsession is asking, where can we go on your website to get sperm testing done for sperm count and DNA fragmentation? Thank you. I love you. Thank you for all you do. Okay, here we go. meetfellow.com/egg whisper. That's one sperm count test. There's another cool test, pathfertility.com/egg whisper. That's a cool test that tells you if your sperm chronological age is older than you or younger than you, right? That's kind of cool. I mean, if your sperm age, I said that wrong. If your sperm age is older than your chronological age or younger than your chronological age. And then for sperm DNA fragmentation, you can go to the scsadiagnostics.com, and that's where my patients order. These are all do-it-yourself tests. You don't need to come into the clinic to do this anymore. Thank goodness. These are validated, really good tests that you can trust, except I've had a guy look at me like maybe the mailman was going to steal his sperm. I'm like, no one is going to steal your sperm. Don't worry. Okay, this next question is from Jenna. Jenna says, hi, Dr. Aimee, can 2 hive stems hurt egg quality? Do you recommend high stems for patients with DOR? And the answer is no, it doesn't make sense. Why would you stimulate like 3 eggs like that? Like, why would you send like 450 units of medications just for 3 eggs? Like, it makes no sense to me. So I find that in my experience, it makes more sense to use a mini IVF approach. I mean, we're still being super aggressive by doing the IVF part, by doing the egg retrieval, but we don't have to stimulate you with like 600, 900 units of medication a day to get what we can get with a much lower dose of medications. I don't like talking about frying eggs. I just feel like, you know, everyone has their style, and I don't want to talk poorly about someone else's approach. But I just feel like we all have our own approach for different situations, and just talk to your doctor about why they've chosen that protocol for you, what they expect to get, what does your IVF pyramid look like. Remember that IVF pyramid is basically the normal IVF attrition that goes on during the cycle, and talking about that IVF pyramid, right, is really helpful. I don't know what that dance was. Just looked funny. Okay, do you recommend ubiquinol? I recommend CoQ10 or ubiquinol. The brand that I usually talk about a lot is the Theralogics brand, and if you go to their website, it's the Neo Q10, and again, you can use the code TUSHY, all caps, for the PRC price. That version has 125 milligrams of CoQ10, but it's compounded with something called Vesizorb. Vesizorb makes it equivalent to closer to over 700 milligrams of CoQ10. So you just need 1 capsule a day. Can you take 2? Absolutely. 1 or 2. Okay. How long does a cycle from start to finish of fresh or frozen take? So a fresh transfer takes basically 17 days from start of your cycle to the end. A frozen embryo transfer can take up to 2 to 3 months, depending on whether you're going to do embryo transfer testing like the dummy cycle or mock cycle in between the IVF and the transfer. Next question is, does HGH help egg quality and improve chances for blastocysts? I'm over 40 and my protocol is long Lupron with estrase and HGH priming. The answer is yes, HGH might help. Talk to your doctor about their experience and see what they think. I've done 2 egg retrievals and I got 12 to 16 eggs, both times less than half were mature. My doctor is saying that I have an egg quality maturity issue. What can I do to help for the next round of IVF? Stephanie, that's one of the biggest IVF challenges that we face. And here are my tips. Here we go. Grow the eggs a little bit bigger, maybe 20 to 22 millimeters. Make sure, though, you're not going to ovulate on your doctor, right? Because that's a really bad day when that happens. Check your progesterone levels, maybe your LH levels. Make sure you're triggering at 36 hours. However, I have found sometimes triggering at 37 hours gives me more mature eggs in cases where a patient has an egg maturity issue. Consider a dual trigger. That has been shown in poor responders to give you a better outcome. So that means HCG plus Lupron. Then look at the amount of HCG that you're taking. If you were taking 5,000, maybe go up to 10,000. So those are my little tips and tricks for hopefully improving your maturity rate. And the other thing is maybe HGH would help too. Next question, I'm 29. I currently have 2 frozen embryos and 1 is being tested now. Excellent. Okay. There's a lot of talk around eating healthy supplements and exercise for healthy eggs, but what about sleep? I'm a night owl with bouts of insomnia. Do I have to worry? I don't think you have to worry, but I would recommend sleeping. An abnormal circadian rhythm could potentially hurt your egg quality. So especially leading up to your IVF cycle, and especially in your IVF cycle, try to get to bed by 10 p.m. That's what I would recommend. Next question is, I keep getting big functional cysts and they seem to be messing with my ovulation for months. I don't have PCOS and my doctors don't have any real answers for me as to what to do about it. Any advice? Yes, check your AMH level. If your AMH is low, it could be that you actually have a high FSH kicking off these follicles, and that's why you have these cysts. See where you are at. And what I mean by that is if you're at that point where you're like, enough's enough, I just want to get to my IVF cycle, drain the cyst, especially if it's estrogen secreting. If it's not estrogen secreting, it's just sitting there and not too big, you can start the cycle without waiting. Consider other types of starts, like a random start. Like you don't have to start your medication at the beginning of the cycle. You can start at another time, like mid-luteal. Next question is from Steph. I'm 36. I retrieved 2 eggs and they were immature and disintegrated after retrieval. I've been taking all the supplements for 7 months, acupuncture, overall healthy lifestyle. What else can I do? Steph, try red light. Try it. I've seen some good stuff recently. I'm going to buy a red light. I'm going to have it on when I'm doing this show. I'm just going to put it, it's that belt over your tummy. And don't look at me like I have a horn coming out of the middle of my head because you're like, what is she talking about? This red light nonsense. You know, when you've been through as much as you've been through, all you guys, and you're like, I still want a chance. I still want to try with my own eggs. You're like, I'll do anything. I think this makes sense. I don't think it's a big deal to get the red light. I don't see how it can cause any harm. Google LLLT and Japanese and then egg quality and red light and laser baby, and you'll see what I'm talking about. And I'll let you know what I find from doing it on myself and my hormone levels. And I have a few patients that have been doing it successfully. Next question is, I'm 39 years old and no normal embryos in my first IVF cycle. What could I do? So ask your doctor if any of the embryos are mosaic. Ask them about the protocol and what changes they would make. Look at the sperm quality, get all your official reports, and see if there's anything you can do to make the sperm more sparkly at the time of egg retrieval so that you can hopefully have a higher chance of having a normal blastocyst. And the other thing, you're making blastocysts. I mean, that's really good. So I would say consider trying again, and then ask yourself, what would I do if this next cycle didn't work? Is it time to consider other options? And then go from there. This next question is, hi, I have a day 6 embryo that passed PGS testing. I'm waiting my ERA this month before transfer. I'm 43 in June. Any advice to optimize it taking? I did 3 IVFs to get this one and a million IUIs, so I'm hoping. So I think you're doing the right thing. The ERA sounds perfect. I would also consider doing the Receptiva DX at the same time. If you haven't done a saline sonogram in the last 6 months to a year, consider doing that as well to make sure there isn't a uterine polyp, scar tissue, septum, something like that. I'm very picky about linings. If I see even the smallest thing, I'm like, we cannot move forward. Make sure you've done all your preconception labs, for example, looking at your thyroid level, so that you know ahead of the transfer that you've optimized everything. What do you think about glue? So there's something called embryo glue. It's a great marketing. I mean, whoever came up with it, brilliant. Does it really do what it says it does? You know, again, every embryology lab will have their own special sauce. If there really was a glue, believe me, we would all be using it, literally. Okay. I was about to do an ERA, but on day 13, I had a big follicle and high estrogens. They had to cancel. I asked if they could do an IUI at the time of my IUI, and my egg had released. Is that okay? And the answer is yes. Eggs sit in the fallopian tubes. They can sit there anywhere from 6, 14, 24 hours. So even if the follicle has collapsed on the day of your IUI, it's okay. It's possible that you still timed it perfectly. Next question, is it okay to try again after a miscarriage? I had 3 back-to-back miscarriages in a span of 6 months. I'm wondering if trying back-to-back hurt my chances. No, Kane, there's nothing that you did to cause the miscarriages. It didn't hurt your chances. But talk to your doctor about the angel workup and see if they've done all those tests that I talk about so often. Next question is, why do you think my estrogen was high even though I was taking estrase? Well, estrase causes your estrogen to be high, so that's why. Hello, do you add any medications for an FET when the patient is positive for anti-nuclear antibodies? Already had one miscarriage from IUI. So the thing with ANA is that when your ANA is positive, you have to say, do you have joint pain? Do you have any risk factors for a rheumatologic disorder or disease? ANA can be positive in the population in about 15% of people. That's super high. I have an aunt. She's a rheumatologist. I'm always calling her. I'm like, what do I do? What do I do? What do I do? And I'm actually going to call her after this because I have a patient. I'm like, send me a photo. I need to call my aunt and ask her, what do I do? Long story short, there isn't anything I necessarily do other than perhaps refer you to a rheumatologist if, let's say, we do a workup and that comes up positive for something. And if I'm not an expert in something, I'm always going to defer to the expert. Next question, any tips for inserting a progesterone suppository? Ooh, that's a good one. If you're using your finger, just use your finger and pop it in, just with the tip of your finger. If you're using an applicator, let me see if I have an applicator. I can't find my applicator. Where is my applicator? I have gum. I have whiteout. I have syringes and needles. Ah, here it is. Whoop, found my applicator. So when it comes to the applicator, all you're going to do is do this and go like that. And then do that. And you're like, voila. That's how far it has to go in. Okay, so that's how I do things with that. Next question is, I'm 39, AMH is 0.6, AFC 3 to 6, 2 cycles canceled, lead follicles 15 and 17, poor response in early ovulation. Should I prime 10 days with estrogen and progesterone and ganirelix, avoid letrozole next time? So I would repeat your AMH and see where it's at. If you have 2 lead follicles, I would say try, I don't know about avoiding letrozole. I like letrozole, but I would say maybe come in treatment day 3 or 4 so you can start ganirelix early. I don't necessarily think that you need to prime for 10 days. Maybe try priming for 3 days because that might suppress you too much. So maybe find a happy balance between 10 and 3, something like that. Next question is, what do I think about IVM? IVM stands for in vitro maturation. It would be amazing if there was such a thing. It would be incredible if it actually worked. That basically means that I could just take a needle, stick it in your ovary, and withdraw eggs anytime. Wouldn't that be great? I wish there was a way to do that. I wish you could just walk into the fertility clinic and be like, I'm ready, get my eggs, ding, you know? Unfortunately, there's a lot of things I wish. I wish you could like walk in, it could be like an airport scanner, you know, and then I'm like just freeze, I push a button, and then out comes all the data, right? Your TUSHY check right there, your follicle count, everything. And I don't have to do the wand thing. Like, oh, I feel we have to get some better technology here that's way cooler. I mean, if Elon Musk can go to, go to space, I feel like we can develop better fertility tests for people. Okay. Anyways, I don't even remember what you were asking. You were asking about the IVM. So as far as IVM, it works very little of the time, like almost never. So that's the hard part. So if you have a doctor that's saying IVM is great and I recommend it, I would say, well, how many live births have you had from it? And are there any patients that I can talk to that have done it? And be like, question that. Okay, next question is how to prepare for a frozen transfer. What do you think of a 3BB 5-day embryo? I feel like it might not work. My husband has DNA fragmentation issues and the embryo was a result of TESI and ICSI. I would say there's a good chance it would work, especially if it's genetically normal. I mean, ask your clinic directly. If you were a patient of mine, I'd say probably at least 60%. So talk to your doc about that. Okay, I'm taking folate 1,000 micrograms and 400 micrograms of my multivitamin. Is that too much? The answer is no. Next question is chromosome testing done in the office or with an at-home kit. So unfortunately, chromosome testing does involve going to a lab and getting a blood draw. It's usually it's a tube that has a green colored top. Does a subserosal fibroid 2.7 centimeters cause problems with implantation? So think of a subserosal fibroid like this earring that I'm wearing right here. It's just kind of dangling there, right? It's not going to affect your fertility or the inside of your uterus. So talk to your doctor and confirm that they agree. What can you do to help the bloat and the discomfort if you have OHSS after an egg retrieval? Great question. Here we go. Whey protein, salty drinks, Propel, G2, Gatorade, V8, Hespan IV, bromocriptine, Femera, Gas-X, Colace, ganirelix. You can start ganirelix even after the egg retrieval again if you're feeling like the bloating is not going down. So those are all the ways you can manage OHSS. And then unfortunately, the best thing that we do, and it's so annoying, is like wait. So it's the passage of time that really helps. Okay, someone is saying, Dr. Aimee, I just messaged you about freeze and share. So you guys, I have a program called Freeze and Share where if you want to freeze your eggs, in exchange for donating half to a recipient that you approve of in an open way, in an open relationship, two-way, where everyone's like, this is awesome. We're going to, you're donating basically the gift of life to somebody else. Freezeandshare.com is for you. Let's see here. What is the best ideal endometrial lining thickness? Can endometrial lining be too thick? And the answer is, it could be too thick, but when it's too thick, I think about whether there's polyps in there. So for the most part, if I see a gorgeous lining, it's like 15 millimeters, even though I usually say 9 to 12 millimeters is my goal. If it's 15 and it's gorgeous and trilaminar and I'm just like, oh, the prettiest feather, then I'm like, thumbs up, we go for it. But if it looks like kind of lumpy and I'm like, I wonder if we're growing polyps in there, then I'm like, time to do a hysteroscopy and we're not going to transfer. Is implantation rate lower for an embryo that gets stuck in a catheter during a transfer? The answer is no. Isn't that nuts? So the way I think about it, if that embryo is so sticky that it won't come out of the catheter, then I'm thinking to myself that that embryo is going to be pretty sticky inside the lining of your uterus. Okay, guys, I'm going to pop off. I have a whole list of patients that I still need to call, and so I'm going to go do that. I love you guys. Thank you for being here on Ask the Egg Whisperer. I'm going to sign off tonight for the week, and guess what? I'll be here next week. Super excited, ridiculously excited to take your questions. Go to asktheeggwhisperer.com. Sign up for one of my IVF classes. Go to eggwhisperschool.com because, you know, having one-on-one time with me for an hour with 20 other people, I can't imagine anything that could be more fun. So thank you guys for joining me tonight. I love you all, and I'll see you next time. Have a great night. It's been fun answering your questions as always.